growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here on The Lionhearted once again. For those dentists like myself who are dedicated to doing whatever we have to do to stand tall, to be brave, to do what we need to do dentistry on our terms. You know, I come up with these little things once in a while when I start these podcasts because I think about, like, why am I doing this? You know, and think back for a minute, all of you listening today. Think back to the moment in college that you thought you might want to be a dentist and the thoughts that went through your head. Did you think about, wow, you know, I can't wait to put in 4 years plus in graduate school for the hope that I could work for insurance companies who dictate what kind of work I do and the maximums per year? That's the kind of practice I want. Or work for a large corporation that dictates your philosophy of care, your practice, your hours. So yes, don't feel bad. In the beginning, my dad was a dentist and I had 3 different jobs. By the way, today's subject is going to be the number 1 skill set in case acceptance. And I'll get back to that in a minute. That will help you achieve phenomenal case acceptance. But back to what I was saying, that's how I started. I worked for my father. My dad had a nice mom and pop type of practice, nice reputation. It's in 1980, and dentistry looked a lot different back then. The skill sets that the average GP has today, most didn't have back then. But there were clinics back then as well, and my dad was like your regular, good, clean, knew a lot, but it wasn't an amazing practice. And I was a little scared, to be honest with you, whether this is where I wanted. Was this the direction I wanted to go in? And so I did a number of things. I worked for 2 other offices. One was a mill. So I worked for 2 other offices, worked for him, and I started a second practice on my own, which ultimately failed. And by the way, the reason it failed, I was in it 1.5 days a week. I would drive down after work, I swear this is true, 40 minutes on a Thursday. I'd work Thursday night in this office that I rented from a pediatric dentist. And then I would work the next day on Friday there. I went on with that for about a year. I slept in that office, by the way. It had a little tiny shower. And I did. I slept in that office. That was my early couple years. That's what I did. So you don't have to apologize to anybody for whatever you have to do in the beginning to find your way. But don't lose sight of what you really signed up for. Don't let it turn into 5 years or 10 years. Because quite frankly, in my opinion, it'll become toxic to you. That's not what dentistry can be. Dentistry can be a 4-day work week, first of all, eventually. Maybe no nights down the road. I haven't worked nights in 20 some years. Okay? Remember, you got to prove and establish in your community who you are and why you're worth it. And many of you are doing that. And many of you are on the way to doing that. It's just the process. If I had to do that today, all the energy I put in, I don't think I could do it. I mean it. If I had to start over today and put all the things into the equation from the time it required, all the groups I joined, all the mistakes I made, all the things I did, it's kind of like, that's why you don't have kids when you're in your 60s either. That you're meant to do that stuff in your 30s and your 20s, trust me. So it's kind of a very similar analogy if you ask me. So listen, that's why you're doing this. That's why you're listening to me. That's the dream. The dream is a 4-day work week. The dream is working on patients each day that you're not worried about whether you're getting paid. that your fees are structured so that on the high side, now you can't just do that if you don't work for that, if you don't train for clinical excellence, if you don't take courses, if you don't surround yourself with a team, and all of this is in my podcasts, that has Ritz-Carlton Four Seasons people skills, that's accountable, that knows how to communicate with patients. If you don't do all that, then there's no reason for people to come to you. But the dream for me, more than anything, to be honest, is going in and being able to do a great variety of different types of dentistry each and every day. It could be from free gingival grafts to root canal to implant dentistry, crown and bridge. I mean, that kept my fervor alive all these years. It's me not dealing with toxic insurance companies. And I did for years and years. And they weren't so toxic, by the way, 25 years ago. So this is a new challenge, a worse challenge for you guys. But you can beat it. This is not a mirage that I give you. Why would I do this if it was? This is real. That's why you tune in. That's why you listen to me. You know, last week we talked about the recall visit, how important a recall visit is in nurturing and maintaining the relationships of the people in your community, whether you're over there in Chile or Poland or France or Italy, wherever you listen to me from, or here in the United States, that chose to come to you. Now, why did they choose to come to you? Well, they chose you because of branding, of your reputation. You know, we've covered lots of these things. This is a very complex picture that gets you to this thing I keep talking about, the dream. But that is the dream. And working primarily on people that appreciate you. Not all the time, man. You got to know that even in my model, there are clearly days of the year where I wonder how whatever's happening in front of me could be happening. Not many anymore, because I've learned a lot of lessons. But I hope you understand that's what this is. That's what this Lion-Hearted podcast is. It's coming from a guy that wants you to live the dream, that knows that you can still do that even in 2020, no matter where you are in the United States. You know that's true. You know that in your communities worldwide, there's somebody out there that is training or trying or putting together different things, maybe a little bit better than you, which is nothing wrong with that. One of the other things I did early in my career is I visited successful dentists. Many of them blew me off. Some of my trips were a waste of time to go see a guy. I'd go there and travel an hour and a half and get there, and he forgot that he had this to do or that to do. I mean, I've done a lot of things, and some of them resulted in disappointment. But that's, I guess you call that kissing the frogs. But let's get to today's subject. You know you can write to me, and I really appreciate that because it tells me you're listening. And you can ask me questions or just say, keep it going. A lot of you do that. You got to remember something. I'm just a person over here. And I'm sitting in here right now in my kitchen on a Sunday doing this podcast because I have lectures coming up and I wanted to be there that next day, because one thing I haven't done is I haven't missed. By the way, don't hesitate to go on the RasnerInstitute.com when I'm thinking of this. If you want to see where I'm speaking in 2020, or if you want to come visit me at the office and learn some advanced or even intro surgical skills, which you know is one of the triads that I give you. You always hear me talk about the triad cornerstones of success, and that would be an oral sedation permit. Even if you didn't do surgery, I would tell you, as I have in recent podcasts, to get an oral sedation permit, because it's the one thing you can do that will blow your phone up. Meaning within 6 months, if you advertise it, people will distinctly come to you because you provide sedation. I'm talking about enteral sedation, oral sedation. The second triad would be learning to take teeth out when necessary, and I don't mean wisdom teeth. I don't think there's enough return on investment for you to take wisdom teeth out. And I think the post-op morbidity whether it be in the possible complications, whether it's vascular or neurologic, are too significant for that return on doing that procedure. So that's just my opinion. But we will learn everything else. We will learn how to take teeth out, any tooth, broken to the gum on a bruxer with giant buttresses of buccal bone and long roots. Any tooth we can get out. And I can teach you as well how to do it atraumatically, which in my opinion, or my view, means leaving 5 walls of bone. And if we don't leave 5 walls of bone, or one of the walls is already gone, then we also emphasize in that course site development, which means bone grafting. And then the third skill, if you're going to learn that, would be some level of surgical implant dentistry. And that's an important thing for you to hear me say. I said some level of surgical implant dentistry. Just because you take on implant dentistry doesn't mean you have to worry. I see social media. It doesn't mean you'll eventually have to learn how to grow horizontal and vertical bone and do ramus grafts or sinus lifts. You can have a robust part of your practice just doing easy, abundant bone implants, and I see zero wrong with you doing that. In fact, I would encourage you to do it. I think what happens to some of us, and I understand it, is that you get carried away with the excitement of the potential and the possibilities in bone grafting and implant dentistry. And you see things online and say, oh my God, I'm not as good as that. I don't know anything. Even I feel that at times. And I've been doing pretty advanced implant surgery for over 20 years. And even I look at some of these things online and say, what are they doing? And listen, you got to remember, you got to also look at your particular market. And do you have a market that's worthy of you investing at certain extreme levels? I'm talking about vertical bone growth in regenerating bone, which requires bone plates that you harvest from the ramus. Even if you knew how to do that, do you really have a market? And I know that may sound myopic for me to say that, because you may be saying, well, how would you know if you don't have a market, if you don't know the skill and you don't offer it? I've been in my territory for 39 years. And I've done it, by the way. Certainly I've done horizontal augmentations with bone grafts and plates. Can't say I've done too much of vertical. But anyway, I'm getting off the subject. There are the 3 cornerstones. And let's get to the subject at hand today, and that's, what's the number one skill for case acceptance? Does anybody know? Would it be your diagnostic ability? I think you know what I'm going to say. It's your communication skill. And I got to tell you, it's a skill that everybody should work on. I'm a pretty decent communicator, and yet I find myself more and more tuned in. And that's what it's about, man. It's all about your focus at the moment you're in with that new patient. And you've heard my dialogue before about how I go with my protocols, about how I go through the new patient visit. But I got to tell you something, man. It all happens in those first couple of minutes. Do you know there's been studies done by, I think the researchers from Princeton were Willis and Tadova, about how people make judgments about you in the opening nanominutes or seconds that they meet you. So if you really want your case acceptance to go up in 2020, the very first step's the easiest. That is, when you walk into the room, look good. If nothing else, look clean. Take a minute to go into your restroom before you go in. Brush your teeth, fix your hair, look at your face, make sure you have nothing on it. I'm dead serious. You're not going to get a second chance. Number 2, if they indicated at the phone call when they first called you that they had significant need, do everything possible to communicate the importance of having the significant other in that room at that first visit. Why? Why would you not think that? In 2020, if you do comprehensive evaluations, it's almost impossible on most patients not to run into the potential need for treatment. It doesn't mean they'll do it. That could eclipse $5,000 to $10,000 in a New York second. And who makes that kind of decision generally on their own? Not many people. That's the simple reason why. Give it all you got in the very first visit, the very first moment. And then when you go in, be perfectly clear. Look them in the eye. Get good at that. I wasn't always good at that. I'm looking at you in the eye right now. Those of you that can see me. It's easy to look away. You can't do that. Radiate warmth. Smile once in a while. It's easy to not be aware of these things. Speak slowly. Speak with passion. If you're not passionate about all this stuff, then you got the wrong podcast. Okay, so talk with passion. Lay out the grounds of who you are, what office that they came to. I've given to you that in many other podcasts where I tell you to discuss the way and the need for a comprehensive care exam, because the mouth is unlike any other part of the body. It doesn't speak to us when there's something wrong. So when there's a fever, you don't need a physician to tell you have a fever. When there's a skin rash, you don't need a dermatologist. But we're dentists, and much of what we treat, patients can't literally see. They can see what they called you for, but they don't know the rest of it. You know, I find it amazing that we don't elaborate on this subject, this moment that I'm talking about right now, because it's everything. To convince a person who's gone through a period of their life, in most cases, where no one's ever talked to them the way I'm talking to you right now, to speak to your patient. In other words, you must know that the majority of the profession seems to be fine with just treating symptoms. That's why you see on so many occasions a molar that had root canal and a crown that is on a severe 45-degree angle because there's no tooth in front of it. Because that tooth hurt the patient. It probably had solid bone enough to justify that. But rather than uprighting it with ortho, why didn't you upright that tooth with ortho? Why didn't you bone graft and consider or even talk about replacing the tooth in front of it? And I know the answers because in many cases you think the patient wouldn't accept it. The comprehensive practice thinks that way. The myopic one-tooth practice, insurance-driven, thinks treat symptoms. So the option given for the 45-degree angle patient was either root canal crown or extraction. And I don't know exactly what would happen in my practice, but a long talk would have preceded that. So communication is everything. And a good time to tell you about communication is when you are with the terminal dentition patient. So you're with that patient in the chair that may have, I don't know, maybe have 6 upper teeth left. And same on the lower. And they're scattered and they may or may not have perio, but they need serious restorative work, orthodontics, everything. And it's a patient that often doesn't have the funds for that to happen. And now you are in a position of denture versus implant retained denture. So that patient, as soon as it's clear to anyone, and my lowest level, newest dental assistant who might have taken the x-rays knows from the x-rays that there's a limited amount of teeth here, will get a tub of models that I have out that have all kinds of implant restorations in them and dentures. But I didn't always do this. Okay, and I really think it's not even optional anymore. You have to present like this. So when you start to speak, when I am talking to the patient that may need a denture, I have a model articulated of a maxillary and mandibular denture, finished on a nice clean model. I take it in my lap. I don't threaten the patient in any way. I say, listen, the purpose of this next couple minutes, I'm just honest, and I want you to convey that. See, that's communication. I don't want to be a chance that they don't understand where this is going. I recently had a patient who'd come to me for 5 years, that I've talked out of a full upper for 20 years. You know, one of those patients comes in, I just pull on my teeth. And she only had like 5 teeth remaining, but they were stable. And I talked an implant case with her. And somehow, some way, she got her way. And last year, she went to a full denture, upper denture. And has come in for I don't know how many post-op adjustments. There's really nothing wrong I can see. And sometimes she comes in and cries. And I know I can say it's not my fault. I tried everything I could and I did. But thank God I did, because I would really feel a tremendous amount of guilt. So communicate at this particular patient with 3D models. I will hand them the denture, literally in their hand in the operatory chair. And I say, see, this is a denture. And you see how this covers the roof of your mouth. I'll have a nice presentation of photos in my room of potato chips and ice cream and other foods that patients eat that will impact the taste of those foods when they cover the roof of their mouth. I mean, I don't know how much clearer you can be. That's what it is. Or if it's a partial denture, obviously there's different types of partials. Or if it's an implant case, even an implant case, I think it's imperative that they actually feel it. Literally, they hold it, they see it, they know it's removable. Some of them, they're spending $25,000, $30,000 on one arch. They assume in their mind that it's fixed, which I know we have that treatment option, but I want them to know what it is. That's my wrap on communicating for the terminal dentition. They are visually seeing it. There is not a chance that they go into this treatment plan not knowing what the process is. And by the way, in case you haven't heard me say this before, my process for all dentures, if I can retain at least one tooth bilaterally, even, the tooth's going to be extracted at the end, but I like them to wear a provisional partial for 3 months while they heal. Even if it's a tooth with a periapical abscess that's asymptomatic or broken down, I might build it up a little bit with real quick composite or an IRM filling. Now, sometimes the perio is so involved, I can't do that, and I'll go right to an immediate denture. But the advantage of the transitional denture is that, number one, they get something right away, right? They're coming in with you with just an incredibly unesthetic interior case. You can picture this in your head. And they, within 2 weeks, they have, albeit a provisional, but it looks a lot better. Number two, they get used to wearing something, so when they make the final leap to the denture, it's not as psychologically traumatic. And number three, it gives you the opportunity to try in the final case, all the teeth except the 2 you kept on each side. So that's the reason I use transitional. I don't do it for the fee, but I've never done it any other way in my career. I don't know if that's what you're doing, but there's a little clinical caveat for you on this particular podcast. Next time, I'm going to talk to you about put the fires out case. That's the patient that comes to you that can't afford the restorative or implants, but they really aren't a denture case. So that's a case that can also get quite expensive and has to be communicated very clearly. It's the patient you're buying time for. And it very often involves long-term, temporary, acrylic partial dentures with cast clasp. So you're trying to buy them 3 to 5 years, but we'll go over that in great detail. And I find that a nice alternative for patients who don't want to go to a totally edentulous situation, but they can't afford the alternative, and this is kind of in between. Hope this helped you guys this week. Make sure you write to me at Dr. Rasner at AOL or find me on the RasnerInstitute.com. And look forward to seeing you next week on The Lionhearted.